اجازه میدیم برنامه رو شروع کنیم؟ البته ببخشید من تو گروه یکی دارم از من پسورد رو میپرسم با اینکه از قبلا بهشون گفتم اگه اجازه بدین 2 دقیقه صبر کنیم چون که فکر کنم همه دارن جوین میشن یکی یکی. 2 دقیقه اگه اجازه بدین.
همیشه خوبه 5 همیشه 4 دقیقه 5 دقیقه صبر کرد تا همه
اجازه بدین بهتره. مرسی.
خارج تو شما ورودی 76 بودین درسته؟ یا 75؟
هیچ کدوم بهمن 78 شما میخواین مثلا که منو بیارید
78 بودی؟
بله بهمن.
شما پس نسل بعد از ما این جورایی. اسپیکرهای دانشگاه تهرانی خیلی بکنم نصف تقریبا گریجویت های دانشگاه تهران بودن تا حالا اگه اشتباه نکنم.
خب اگه اجازه بدین شروع کنیم چون که از اون ممکنه طول بکشه. Hello everyone, it's about the time we should start the program. This is a great honor for all of us to virtually have you all here. I am Dr. Maryam Yazdy, Associate Professor of Medical Genetics at Oncology, Hematology and Cell Therapy Research Institute and head of the leading house for Iran North America Academic Partnership, which has set up this series of educational programs in cooperation with Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington, who kindly facilitated this connection between Tehran University of Medical Sciences and great hematologists in the US. Today, Dr. Shadman is the moderator of this program, and I would like to ask him to introduce our valued guest speaker, Dr. Maryam Sarraf Yazdy, hematologist and oncologist from the US Food and Drug Administration. I hope you will find this webinar informative and helpful. Dr. Shadman, please.
Thank you, Dr. Yaghmani, and hi to all colleagues in Iran and other countries who are connecting this afternoon or evening or morning, depending on where you're connecting from. So it's a real pleasure to have Dr. Maryam Sarraf Yazdy as our speaker today. She is a graduate of Tehran University and moved to the United States, finished her residency training at Howard University, followed by fellowship training in hematology and medical oncology at Georgetown University, where she stayed as a faculty, as an assistant professor, active and involved in studies on lymphoid malignancies, chronic lymphocytic leukemia. And she was leading many studies, therapeutic and non-therapeutic in those areas. And then she moved to the US Food and Drug Administration, FDA, where she works as a hematologist and oncologist in a division of hematologic malignancies on the lymphoma team. And she's responsible for reviewing basically new drug applications and investigational new drugs in the area of lymphoid malignancies. So today is a little bit different than our other talks for a couple of reasons. Dr. Yazdy is a FDA medical officer or employee, so she's limited in her talk in only talking about drugs for follicular lymphoma or treatments for follicular lymphoma that are FDA approved. So she won't be talking about any investigational drugs that are not currently approved for follicular lymphoma, which should not cause any problems because we in Iran, we don't have access to those agents anyways, but it is important to sometimes talk about some of the new agents. So during the Q&A, I will try to cover some of those investigational agents very briefly. I don't have any slides or anything, but just to talk about them. Secondly, you can imagine how difficult it is to have somebody from FDA get approval for giving a talk. So I would like to thank our colleagues at Tehran University, Dr. Yaghmani, and all the TUMS administration who really did this paperwork and requests, and also FDA and Dr. Yazdy who agreed to do this. It took a lot of work to get this approved, but I'm really happy that Dr. Yazdy is with us today to talk about mainly follicular lymphoma and indolent lymphomas. So with that, Dr. Yazdy, please go ahead.
Thank you, Dr. Shadman and Dr. Yaghmani. It's a great pleasure to be here today, and I look forward to our discussion. So I'll go ahead and start sharing my screen. Hopefully everything will go as planned with the sharing. Okay. Please let me know if you're able to see my presentation in the full presentation mode.
Yes, it's good.
Okay, perfect. Okay, so as Dr. Sharman said, I will discuss about treatment of follicular lymphoma today and mostly approved therapies. I don't have any conflict of interest. So first, I will mostly cover epidemiology, pathology, some grading and staging and risk stratification. And then I will move to discussion about management of untreated follicular lymphoma and relapsed refractory follicular lymphoma. Follicular lymphoma is a B-cell lymphoproliferative disorder with a generally indolent course, as you know. As the second most common subtype of non-Hodgkin lymphoma in Western nations, follicular lymphoma constitutes 12% of all non-Hodgkin lymphoma diagnoses. In the United States, nearly 14,000 new cases of follicular lymphoma were diagnosed in 2016. At diagnosis, the median age of patients is about 63 years. And although most patients present with asymptomatic lymphadenopathy, the majority are diagnosed with disseminated disease. Despite its generally indolent course, it is important to know that there's approximately a 2% risk per year for the disease to transform into an aggressive lymphoma, such as diffuse large B-cell lymphoma, which, as you know, has generally an adverse prognosis and different management compared to indolent follicular lymphoma. And it's good that many patients with follicular lymphoma can go multiple years without requiring any therapeutic intervention. However, some patients do need therapy at diagnosis, which we will discuss shortly. What is the process for development of follicular lymphoma? A key event occurring very early in the development of follicular lymphoma is the characteristic translocation between chromosomes 14 and 18. This translocation involves the BCL2 gene and thus leads to dysregulation of the anti-apoptotic BCL2 protein, and thereby providing B cells with an anti-apoptotic advantage as they continue their development in the germinal center of a lymph node. The expression of activation-induced deaminase, an enzyme possessing mutagenic capability, leads to sporadic mutation in different genes such as CREP, MML2, EZH2, and other genes. And the accumulation of these mutations further helps with this malignant progression of the B cells to follicular lymphoma. Something that is, I think, interesting is that the translocation of 14-18 can be detected in individuals with no known diagnosis of follicular lymphoma. That, this suggests that this translocation alone is not sufficient for development of follicular lymphoma, and if other, mutations and processes are needed. As you see in the slide, in this slide, when viewing a lymph node biopsy from a patient with follicular lymphoma at a microscopic level, the tissue displays a nodular proliferation of small lymphocytes that is both characteristic of and important to diagnosis of follicular lymphoma. So how do we grade follicular lymphoma? The grading is essentially a grade is essentially a macroscopic description of how proliferative the lymphoma is, as determined by a pathologist, which has implications for both prognosis and possible treatment. But the pathologist will examine a lymph node biopsy for the lymphoma follicles containing centroblasts, which are large proliferating B cells, along with centrocytes, which are smaller cells that are less proliferated. The number of centroblasts per high power field average across multiple follicles determines the grade of disease. Grades 1 and 2 generally exhibit an indolent course, and 3A could progress more rapidly. In general, in most cases, we treat grade 1 through 3A similarly. But as a 3B, the story is a little bit different from for grade 3B disease, because that's a faster growing, more aggressive disease. And we treat grade 3B differently, mostly with anthracycline, including regimen, similar to regimens for diffuse large B-cell lymphoma. I will now discuss the staging of follicular lymphoma a little bit. So follicular lymphoma, as you know, is generally an indolent disease, and most patients will have few to no symptoms until later stages. Symptoms include painless swollen lymph nodes in the neck, armpits or groin, fatigue or beat symptoms such as fever without another cause, drenching night sweats, and unexplained weight loss. Stage 1 and 2 are often considered to be limited disease. In these cases, the disease is confined to one side of the diaphragm and involves one or two groups of lymph nodes, such as the axilla for stage 1 or the axillary cervical lymph nodes for stage 2. Stage 3 and 4 are considered more advanced disease. Stage 3 disease affects lymph nodes on both sides of the diaphragm, such as the inguinal and axillar, or has spread to nearby organs. Stage 4 disease often has bone marrow or organ development. So what is FLIPI? The Follicular Lymphoma International Prognostic Index, FLIPI, was one of the first robust attempts at creating a validated prognostic index for patients with follicular lymphoma. FLIPI assigns patients to risk categories based on the presence or absence of 5 criteria that you see on this slide. FLIPI score does not necessarily predict the clinical course for a given individual, but rather describes the approximate outcomes across the population with comparable FLIPI scores. For example, a 10-year overall survival of 71% among those deemed low risk versus 36% with high risk disease. But something important about FLIPI is that we should note that FLIPI was created before rituximab era and before rituximab changed landscape, the treatment landscape of follicular lymphoma. And after rituximab became available, then FLIPI 2 was created that evaluated 5 slightly different criteria to make it more applicable to the treatment paradigm. And as you see, the criteria are listed on the slide. And here on the left is progression-free survival curve, and the right side overall survival curve. It shows you the Kaplan-Meier curves in a validation sample of 231 patients stratified by FLIPI 2 score into low risk, and low risk is the top kind of bluish color, and intermediate risk is the red in the middle, and high risk, the green one, lower curve. Since the 1940s, we have observed a steady improvement in survival outcomes for patients with follicular lymphoma. The positive result of both earlier diagnosis and more efficacious treatment. Rituximab, second-generation anti-CD20 antibodies, new targeted agents, and also optimized chemotherapy regimens are all associated with a 10-year overall survival rate of 64 to 92%, and a median survival of approximately 20 years, which is comparable to age-matched group controls. Although follicular lymphoma is typically regarded as a chronic disease with good response to initial therapy, patients usually eventually relapse, most of them, and require additional therapeutic intervention. The current goal of treatment is to maintain the best quality of life, delaying disease progression, but it's sometimes difficult to demonstrate longer overall survival in clinical trials because of the prolonged clinical course associated with the disease. Now let's move to treatment of follicular lymphoma. When should we consider treatment and how? Just to summarize, when a patient is diagnosed with follicular lymphoma, we consider their disease stage, grade, tumor burden, or bulk symptoms, age, and fitness, along with their personal goals and priorities when we are, thinking about treatment recommendations. And we would like to provide all patients with the optimal quality of life and the deepest response possible. But sometimes, we must select therapies that favor one of these goals over another, depending on unique patient circumstances. Here, just wanted to mention GELF criteria that represents an effort to harmonize across clinical studies those patients with high tumor burden in need of therapy. But it's just important to know that sometimes a lot of times patients do not meet all of these criteria. They meet, some of them, and also, again, this criteria is not just a check mark to treat the patients independent of their individual circumstance. So mass with diameter of 7 and larger centimeter, involvement of 3 lymph nodes, 3 or more lymph nodes, where each is 3 or more centimeter in diameter, presence of B symptoms, splenomegaly, compression syndrome, that happens a lot, presence of ascites or pleural effusions, cytopenias, and leukemia. So as I said, it's just very important to look at this, but also consider each patient individually. Patients with follicular lymphoma who do not meet any of the GELF criteria are considered to have low tumor burden. And there's several landmark studies that have informed optimal management of these patients, and I'm going to mention some of them here. One of the questions that come up is for asymptomatic follicular lymphoma, should we do watchful waiting or rituximab? Is treatment needed or not? This is a phase 3 trial conducted by Ardeshna and colleagues that was published in 2014 that randomized 463 patients with stage 2 to 4 low tumor burden, asymptomatic follicular lymphoma to 4 weekly doses of rituximab followed by 2 years of rituximab maintenance. 4 weekly doses of rituximab followed by regular clinic visits or watchful waiting with regular clinic visits. Although originally it was designed as a 3-arm study, this ultimately became a comparison of rituximab with rituximab maintenance versus watchful waiting. Approximately 3 years after enrollment started, recruitment was stopped for the arm receiving 4 weekly doses of rituximab because of slow recruitment and other studies reporting superior outcomes with rituximab maintenance. And the study design was then revised to have sufficient statistical power as a 2-arm trial, comparing rituximab induction plus maintenance with watch and wait. After a median follow-up of 46 months, median PFS was significantly improved with rituximab versus watch and wait. However, overall survival, as you see on the right curve, was similar between treatment arms, with a 3-year overall survival rate of 97% with rituximab versus 94% with watch and wait, and p-value was 0.4. Looking at the performance of the control arm, we can see that slightly more than a quarter of the patients in watch and wait arm did not experience progression within the first 5 years of the study. Also, the investigators observed a subpopulation of patients in the watch and wait arm who interestingly experienced spontaneous remission with a 25-month overall remission rate of 12%. So in summary, in these cases, I would have a discussion with the patient, present data, and what we know to inform them, but generally I tend to select watch and wait, and patients also, they usually, at least, per my understanding, they have chosen watch and wait. And one reason is that rituximab induction plus rituximab maintenance would simply lead to extra costs, some toxicities, and also place a burden on the patient without leading to more favorable outcome and increased overall survival. I will now review some trials, landmark trials, evaluating chemoimmunotherapy in patients with newly diagnosed follicular lymphoma and high tumor burden. So in 2013, Federico and colleagues published data from a phase 3 trial, FOLLOW-5 trial, which was conducted in Europe. This trial randomized 534 patients with previously untreated advanced stage follicular lymphoma to 3 chemoimmunotherapy arms, as you see: RCVP, RCHOP, and RFN. The primary endpoint was time to treatment failure, with secondary endpoints including PFS, OS, cause-specific mortality, secondary malignancy, and safety. A follow-up of a median of 84 months was presented in an updated analysis and showed an advantage to RCHOP versus RCVP for PFS, and lymphoma-related mortality and non-lymphoma-related mortality. Just to point out that the difference between these regimens is that RCHOP contains anthracycline, not doxorubicin. We also see favorable PFS outcomes with RFM, but this regimen had the greatest cumulative incidence of non-lymphoma-related mortality that was concerning. This trial established RCHOP as standard of therapy for patients who were anthracycline eligible at that time, or RCVP for patients who were not anthracycline eligible. I included this slide here to point out that RFM is the red columns, they have more toxicity, neutropenia, other cytopenia infections, followed by R-CHOP, and then in the end RCBP. That's the purple column. Another key trial in the setting of symptomatic high tumor burden disease is STEEL trial, which was conducted in Germany and published in Lancet in 2013 by Rommel and colleagues. This was a randomized open-label phase 3 non-inferiority trial comparing bendamustine and rituximab BR versus R-CHOP in previously untreated patients with mantle cell lymphoma or indolent CD20 positive lymphoma, including about 549 patients with follicular lymphoma. The primary endpoint of the study was non-inferiority of PFS for BR versus R-CHOP. After a median follow-up of 45 months, PFS curves clearly separated in favor of BR versus R-CHOP, with a median PFS that was not reached for BR versus 40.9 months for R-CHOP. However, there was no different overall survival between the treatment arms. Importantly, the R-CHOP regimen had a more challenging safety profile with greater cardiotoxicity compared with BR. This was reflected in the higher rate of serious adverse events, with R-CHOP versus BR 29% versus 19%, and higher rate of cardiac disorder and arrhythmia. Given the safety advantage and improved outcomes relative to R-CHOP observed in this study, BR became a commonly used chemoimmunotherapy regimen in the United States. The other important trial that you see for high tumor burden follicular lymphoma is BRIGHT study. That one was also a phase 3 trial, non-inferior study that was conducted in the United States to compare regimens similar to those evaluated in the STEEL trial. This trial enrolled previously untreated patients, again, mantle cell or indolent non-Hodgkin lymphoma, including 447 follicular lymphoma patients. And the investigators pre-assigned a patient to RCVP or R-CHOP, and the patient was then randomized to receive either that pre-assigned regimen or BR. In BRIGHT, there was markedly less difference in progression-free survival with BR versus R-CHOP RCVP compared with STEEL. Nonetheless, because of the improved safety profile with BR versus R-CHOP or RCVP, this study also further emphasized the role of BR chemoimmunotherapy for patients with follicular lymphoma and needing therapy. I understand that we don't have time to discuss all the important trials, but another study that I wanted to discuss was Gallium. This was an international phase 3 landmark study in patients with, again, newly diagnosed follicular lymphoma. This trial recruited patients with CD20 positive indolent non-Hodgkin lymphoma with high tumor burden, about 1,200 patients, and in a cohort randomized separately, patients with marginal zone lymphoma. Each center decided whether to give all patients CVP, RCVP, CHOP, or bendamustine, with the randomization being whether patients would receive obinutuzumab, the newer CD20 antibody, monoclonal antibody, or rituximab, plus chemotherapy, followed by single-agent obinutuzumab or rituximab as maintenance. The primary endpoint was investigator-assessed PFS, patients with follicular lymphoma. Secondary endpoints included PFS by independent review committee, overall survival, disease-free survival, among other common secondary endpoints. It is a challenge in any clinical trials of follicular lymphoma to show improved outcomes, especially overall survival. But or even PFS, it takes years. But an updated analysis of Gallium study with a longer follow-up time of 76.5 months observed a 24% risk reduction of progression in favor of obinutuzumab versus rituximab. We will cover early progression of disease a little bit later, But I want to note here that also because we saw a decrease in the proportion of patients with progression of disease within 24 months or part 24 with obinutuzumab versus rituximab. At 5 years in the gallium study, there was still no difference in overall survival between the treatment arms. But 5 years is still an early time point for follicular lymphoma studies. Some of the concerns about the gallium study relate to the slightly higher rates of toxicity in the obinutuzumab arm. There was a slight increase in rate of grade 3 to 5 adverse events for patients treated with obinutuzumab versus rituximab, 79% versus 71% respectively. Especially when we look at grade 3 to 5 adverse events of special interest, we see that the rates of infections and infusion-related reactions were higher among patients treated with obinutuzumab. A considerably higher rate of non-relapse related fatal adverse events was seen among patients who received chemoimmunotherapy regimens with bendamustine versus regimens without bendamustine. And because bendamustine is so commonly used in treatment of follicular lymphoma, there is some apprehension around combining bendamustine with obinutuzumab in the frontline setting. A lot of physicians still use BR. So a question that kind of comes up is that should obinutuzumab replace rituximab as the preferred antibody for initial treatment of follicular lymphoma or not? So you can kind of, there are different arguments for using rituximab. So for arguments for using rituximab is that, CR rate at the end of induction is similar between obinutuzumab chemo versus rituximab chemo. Overall survival is similar between the two treatments. Severe adverse events are higher with obinutuzumab arm. And there are, as I mentioned, severe adverse events and fatal events attributed to bendamustine and obinutuzumab combination. But then, kind of being on the other side, arguments against using rituximab is that PFS rate is higher when you use obinutuzumab chemo versus rituximab chemo. And we didn't see really enough follow-up for separation of overall survival curves. So it's kind of a discussion that you can also have with patients, but mostly in the frontline setting, I've seen that physicians and in my opinion use rituximab versus obinutuzumab. But the good thing is that after all this discussion, as we discussed earlier, the outcome for patients with previously untreated advanced follicular lymphoma improved substantially after rituximab was introduced to the treatment landscape, and also now possibly with obinutuzumab in frontline or relapse refractory setting. The other question that comes up, and maybe different physicians and different centers have different opinions about it, is that to use maintenance rituximab in follicular lymphoma or not. So a study that I wanted to show here in patients with low tumor, versus in patients with low tumor burden follicular lymphoma is this RESORT trial. That the trial enrolled about 400 patients with low tumor burden follicular lymphoma. And these patients received 4 weekly doses of rituximab and then underwent a response evaluation. The 299 patients with a PR or CR were then randomized to either rituximab maintenance or retreatment rituximab at progression. The primary endpoint was time to treatment failure, and key secondary endpoints were time to first chemotherapy, safety, and toxicity. In this population, no real benefit was found with rituximab maintenance versus rituximab retreatment at progression. Either strategy led to similar duration of benefit. Some patients in the retreatment arm who experienced progression went on to receive rituximab-based chemotherapy, meaning that the patients on rituximab maintenance had slightly decreased use of chemotherapy during follow-up. This study largely led to use of rituximab without rituximab maintenance, when rituximab monotherapy is the therapy of choice for a given patient. Now presenting a PRIMA study in patients with high tumor burden. So in this study, about 1,000 patients completed induction treatment and were randomly assigned to rituximab maintenance or observation. After data cutoff, median PFS was 10.5 years in the rituximab maintenance arm compared with 4.1 years in the observation arm. But again, something similar to some other slides, no overall survival difference was seen in patients randomly assigned to rituximab maintenance or observation. 10-year overall survival estimates were approximately 80% in both study arms. And as you see, rituximab maintenance after induction immunotherapy provides a significant long-term PFS, but not overall survival. And this could be something that I would discuss with my patients, but a lot of patients would kind of forego maintenance. Now we will start discussing management of patients with follicular lymphoma in relapse or patients who experience disease progression after first-line therapy. It is very important when you're suspecting relapse to consider rebiopsying if possible. And as you know, a sizable number of patients with early progression likely have transformation, and the treatment would be different. And so there was a study by Freeman and colleagues reported that it was a retrospective study of 296 patients with advanced stage follicular lymphoma. So they looked back and saw that 13% of those treated with first-line BR, followed by maintenance rituximab, experienced progression of the disease within the first 2 years. And with 76% of these patients having transformed disease. So something that would be really helpful is that when you're suspecting progression and you would do a PET-CT scan, and the PET-CT scan would really kind of help evaluating possibility of transformation and kind of selecting the best location to do the rebiopsy to make sure that the patient doesn't have transformation. We don't need to change the treatment.
Sorry, Dr. Yazdi, to interrupt. I don't think your slide, okay, it just advanced now. I don't know if it was me or other. Yeah, if you just move one, yeah. Now we can see it, but go ahead. Now you're back
I was
to.
Just talking
oh, you're not showing this. Okay, okay.
No, I was saying.
Sorry.
It's okay, thank you. Okay, so now just a key of talking about early progression. A key observation made over the past several years is that patients who experience progression of disease in the first 2 years or 24 months, that is pod 24 or early pod, these patients have worse outcomes compared with those who experience disease progression after 2 years. For example, as you see, in the survival curve, for patients experiencing early progression versus those who did not when they were treated with R-CHOP, 5-year overall survival was 50% in early progression patients versus 90%. This was a national lymphocare study. So patients experiencing pod 24 are now considered to have uniquely aggressive disease. And as mentioned previously, many of these patients will have might have disease transformation, which again shows that it's so important to consider rebiopsying when you're suspecting relapse disease or progression of disease. The question that topic of discussion is that what's the best treatment for patients who progress early? But specifically, the role of auto transplant. Should we consider that for patients with early progression or not? So and again, you see that based on country or institution or physician, treatment opinions about transplant is different. But basically, in my opinion, younger patients, fit patients with good performance status, and early progression, auto transplant should be considered for this patient, and definitely there should be a discussion between a physician and these patients. I've included summary of data from 3 retrospective analyses here in this slide, that they indicate that patients who underwent transplant had generally better survival outcomes than those who did not. 5-year overall survival rate of 67% to 85% versus 58 to 60%. But it's important to note that these are not randomized studies and are subject to biases regarding who might have been transplant eligible. These curves are from one of the studies that I presented in the past slide from Canada and German low-grade lymphoma study. These are the retrospective analysis. And they can clearly see separation of the curves for patients who underwent transplant in blue versus those who did not. Now let's discuss some of the key studies in relapsed refractory follicular lymphoma. The phase 3 GATHERING trial was one of the first studies in patients with relapsed follicular lymphoma to demonstrate a survival benefit. This trial enrolled patients who were deemed rituximab refractory, which was defined as progression on or shortly after treatment with a rituximab-containing regimen, about 413 patients. Patients were randomized to obinutuzumab plus bendamustine versus bendamustine alone, followed by obinutuzumab maintenance. GATHERING showed a significant benefit for both PFS, which was the primary endpoint, and overall survival. For the follicular lymphoma cohort, the median PFS was about 24 months with obinutuzumab plus bendamustine versus 13.7 months with bendamustine alone. Overall survival was also significantly improved. Whether these positive results affect the standard of care is less than certain because, as you know, many patients will have received bendamustine in the frontline setting, and then very few patients would receive in later bendamustine. Nonetheless, for patients with relapsed disease who will receive bendamustine, I would include obinutuzumab rather than rituximab, especially if they had rituximab refractory disease. In May 2019, supportive results from the AUGMENT trial presented here and magnified in the next slide led to FDA approval of R-square or rituximab lenalidomide regimen for patients with previously treated follicular lymphoma and also marginal zone lymphoma. In this phase 3 AUGMENT trial, 358 patients with relapsed refractory follicular lymphoma or marginal zone requiring treatment who were not refractory to rituximab were randomized to R-square or placebo plus rituximab up to 12 cycles or until relapse, progression, or intolerance to regimen. And then patients were followed for 5 years. The primary endpoint was progression-free survival, with secondary endpoints including overall response rate and survival. The results of AUGMENT show that lenalidomide is active against follicular lymphoma, and those patients who received R-square demonstrated significantly improved PFS versus patients who received rituximab alone. In the final analysis performed after a median follow-up of 28.3 months, the median PFS was 39 months with R-square versus 14 months with rituximab alone. You know, the trial was not powered to detect a difference in survival, and the overall survival data were still maturing at the time of analysis, but the estimated 2-year survival probability that was reported in patients with follicular lymphoma with R-square was 86%. And there has always been some concern that lenalidomide may be associated with secondary malignancies, but this study didn't report an increased rate compared to rituximab alone. But the other concern also with lenalidomide is thrombosis. DVTs were observed in 2% of the patients with R-square versus 1% in rituximab alone. And because of this concern, most patients receiving R-square will often receive prophylaxis with aspirin or some anticoagulation. The other trial that, as I mentioned, also with augments, they led to FDA approval of our R-squared in previously treated follicular lymphoma was magnified. This was a phase 3 trial, was designed to determine the optimal duration of lenalidomide treatment and enrolled patients, about 393 patients with relapsed refractory follicular lymphoma. All patients received an initial therapy, the R-square, for 12 cycles, followed by randomization to maintenance with R-square or rituximab. And the primary endpoint was PFS, with secondary endpoints including overall response rate and safety. And at ASCO last year, it was reported that the best response rate among patients with follicular lymphoma during initial R-square regimen was 70%, including 29% with confirmed CR. And the PFS curves are shown on the right side of the slide at the median PFS of 39.4 months in patients. I would like to kind of mention some targeted agents, PI3K inhibitors. So basically, I don't want to get into the regulatory language at the FDA, but in general, the drugs when they're considered for approval could be considered for something that's called accelerated approval or regular approval. Accelerated approval are the drugs that are usually coming using the intermediate endpoints. There's still some uncertainty about their benefits, but still they show advantage over available therapy. So PI3K inhibitors, as you see the list here, are in the drugs that have accelerated approval by FDA. These, all of them had, the approval was based on single arm trial, smaller trials. And the difference between this and regular approval is that regular approval usually uses, overall survival or endpoints that better show the survival or benefit of this new drugs over available therapy. And for accelerated approval drugs, the drug companies are have to have larger randomized trials with primary endpoints of overall survival or PFS or so to kind of show the benefit still continues in this randomized trials. And they have to show the result of the randomized trial to FDA in a couple of years when the trial is out. If the trial proves that and confirms the benefit, the approval changes from accelerated approval to regular approval. But it's sometimes what has happened in the past that these randomized trials actually do not confirm benefit. The drug can be withdrawn from the market. So in the regulatory language, when we say approval therapy, we mostly mean the regular approval, such as bendamustine or R-square. But these are really important, and in the U.S. are being used a lot, the PI3K inhibitors. So I just wanted to kind of list them here. And they're mostly used for patients who had received prior 2 lines of therapy or 3 lines of therapy in the past. The first one was idelalisib. In the right side, that was approved in 2014, and the most recent one was umbralisib that was approved in February of this year. And most of these trials included patients that had rituximab refractory disease. Overall response rate is somewhere between 42% to 59%, and CR rates are somewhere from 1% to 14% in copanlisib. But something again to just when you look at this table to note is that these agents are not compared head to head in a trial, and data shown here is from separate single arm phase 2 trial. And one thing that we take into consideration when we're thinking about using PI3K for a patient is their toxicity profile, because they all have slightly different toxicity profile that based on the patients can help us choose one or the other. For example, hepatic toxicity and immune-related colitis are the most concerning toxicities with idelalisib and duvelisib, and but hyperglycemia and hypertension are the concerns with copanlisib. And also route of administration is different. So copanlisib is the IV one, the rest of them are oral. Again, choice of therapy should be individualized, really. The other agent that I find interesting, again, has accelerated approval, but I wanted to mention is tazemetostat. That was approved in 2020 for patients with relapsed refractory follicular lymphoma. This is a selective oral first-in-class EZH2 inhibitor, and EZH2, as we briefly mentioned in the beginning of the presentation, is the histone methyltransferase that regulates germinal cell formation in normal B cell biology. And EZH2 mutations are observed in up to 20% of patients with follicular lymphoma, and EZH2 mutations can lead to oncogenic transformation by locking B cells in germinal state and preventing terminal differentiation. So this was also based on a single-arm trial, phase 2 trial. Patients were divided into two groups, EZH2 mutant disease and EZH2 wild-type disease. And as you see, overall response rate was higher in patients who had EZH2 mutated disease, 69% versus 34% in wild-type disease. So FDA approved, granted accelerated approval for tazemetostat for adults with EZH2 mutated relapsed refractory follicular lymphoma after 2 or more prior systemic therapies, or any adults with relapsed refractory follicular lymphoma without alternative treatment options. So I know we discussed a lot, and I really look forward to our QA and discussion and Dr. Shadman's discussion also. But in general, the good thing is that outcomes of follicular lymphoma have improved significantly with most patients doing well on conventional therapy, and median overall survival for advanced stage disease exceeds 20 years. And as you see, there are multiple options available for untreated and relapsed refractory follicular lymphoma, and these are mostly the approved therapies. There are so many different investigational therapies from that are approved. That maybe Dr. Shadman will mention some of them, but a lot of development is happening in this world, and also at FDA, I'm just seeing that so many, there's so many things really happening in drug development. And one thing that still I think we need to work a lot on is patients with high-risk follicular lymphoma and patients who have progression of disease early, and we really need to figure out how to provide these patients with this best treatment possible. If we need to do transplant or CAR T cell or other therapies earlier for these patients, because they have a different kind of disease profile compared to the indolent disease patients. So I'm going to pause here and happy to answer any questions. And again, thank you so much for this opportunity.
Okay, thank you very much for this excellent review. I think we have, let's see how much time we have. No, we're pretty good at time. Okay, so I have, let me start with the questions in the chat box. Starting from the top, Dr. Ashrafi, sorry. So Dr. Ashrafi, she has a couple of questions. First question, in patients who are asymptomatic, but they have bulky disease per Guelph criteria, what's the benefit from treatment? So basically, if you have somebody with an 8-centimeter mass, but they're totally asymptomatic, why would we treat them?
Thanks for the question. What I do is that usually I'm kind of concerned, when they have large masses, because it's usually you think that it's likely. I look back at the time of diagnosis and other when the patient was diagnosed. Does it seem that the tumors are getting larger quickly or just really slowly over years and years. But usually I'm concerned. So I'll have a discussion with the patients and kind of mention that they could consider treatment. And if the bulky, for example, tumor is not causing symptom at the moment, I would say that they don't need treatment urgently, but in the near future. And some patients, a lot of patients decide to start treatment.
Okay, so next question is from Dr. Rezai, and I think it was about, let me find it, a PET scan. What is the role of PET scan in the initial workup and also in the surveillance of follicular lymphoma patients? Is there any Deauville score that differentiates follicular and transformed lymphoma? Or we should probably say, is there any SUV that would differentiate follicular lymphoma and large cell lymphoma?
Thank you. This is a great question. So here in the U.S., and I'm not sure, please tell me about availability of PET scan in Iran and the neighboring countries, but we usually prefer to do PET scan at the time of diagnosis, which helps us with figuring out the staging of the disease. And also the other thing is that if we usually see SUV in a location or a lymph node that is really much higher than other lymph nodes if we are suspecting, for example, transformation disease, to go on biopsy that node to make sure patient doesn't have a transformation of disease. So for follicular lymphoma, I would do one in the beginning, and then I would do another one after about 6 to 8 weeks after completion of treatment. I do not do any kind of interim PET scans, and for the follow-up after that, I do not do PET CT scan. I would consider PET scan again if patient starts developing concerning symptoms, or in my exam I see sudden kind of progression of the disease or enlarging lymph nodes. And then your other question also is very interesting about, is there an SUV that kind of tell us exactly if, okay, this is transformation versus no, this is still follicular lymphoma, you shouldn't be concerned or scared. Is that, as far as I know, no, and Dr. Chalman can also add to this, it's definitely concerning if you see higher SUVs, and I would always consider doing a biopsy if suddenly the SUV is much higher than most of the lymph nodes, but I don't think there is a specific SUV that can tell us this is transformation.
No, I agree. I mean, it just gives you the idea if there is a higher chance of transformation, but the gold standard is definitely biopsy. I have a number of patients I'm following for years, and with SUVs in 20s and 30s, and every time I biopsy, I'm sure it will come back as large cell lymphoma. It keeps coming back as grade 1-2 follicular lymphoma. It's not a common, but yeah, you have to use it as a guide to biopsy. And I agree with PET scan, and also at beginning and end of treatment, that is in fact the most important indicator of early relapse. So you really want a PET negative complete remission after induction chemotherapy. If you don't achieve that, that patient will be in trouble, and then you're talking about transplant, as Dr. Yazdi mentioned. Okay. Oh, I don't know why I muted myself. So next question is also from, so this was from Dr. Rezai, I believe, and then Dr. Ashrafi's next question. So if you have a patient who has a relapse less than 2 years and they're not interested in chemotherapy, so they want to pursue a chemotherapy-free treatment, can you go with, can you do lenalidomide and rituximab and then transplant? And the second question is, can we do lenalidomide maintenance just instead of transplant? So basically, high-risk POD24 patient, doing lenalidomide, rituximab instead of chemotherapy, and doing transplant after that. Is that reasonable?
Yeah, patients with POD24 are always kind of, we get concerned about them. But if the patient doesn't want to do transplant, that I've heard a lot, there are a couple of options that we could always discuss with them. is that I always look to see if we have any good clinical trials available at that specific center or places around that a patient can go to and really look at the list of clinical trials. The other things are, yes, I would discuss the data about R-score and definitely consider that for them. But then the other other options would be CAR T, or would be if they are not interested in any of these, then I would discuss PI3K inhibitors or casonated SAC.
So maybe I can. Yeah, that was the question, but maybe we can. I can explain a little bit, because this is an ongoing trial, and Dr. Yazdi probably won't be able to discuss. So the question of the question of what to do with a patient who has an early relapse, we really don't know what's the best treatment to give them to even make them ready for transplant, right? You can go, if they started with bendamustine, you can give them R-CHOP. If they started with R-CHOP, you can give them bendamustine. You can give them ice or rice, right? You can give them lenalidomide. What is the right treatment for a high-risk patient? So that we don't know. And there is currently an ongoing randomized trial in the US that's trying to answer this specific question. So in patients who either got bendamustine rituximab or R-CHOP rituximab or any other type of CD20 antibody, and they have an early relapse, they are randomized to 3 arms. One would be chemotherapy, one would be actually lenalidomide and obinutuzumab. Obinutuzumab is kind of a CD20 antibody like rituximab, of course. And the third arm would get umbralisib, a PI3 kinase inhibitor, and obinutuzumab. So basically, Dr. Ashrafi, yes, you're talking about one of the 3 arms of that randomized study that's ongoing. So people, of course, think that that's a reasonable option. That's why they put it in the trial. We don't know the results. The study is enrolling really slowly. It's a difficult study, and it's ongoing now for 3 or 4 years, and hopefully will give us that answer. And yes, definitely you can do stem cell transplant after lenalidomide and rituximab. Whether or not you can just do it instead of a transplant, I don't think we know the answer. It's really based on no data. So I guess if somebody's responding really nicely and 2 years later they're in complete remission, you can argue continuing, but I don't think we have any data. So
Dr. Sharma, I have about this, what you just discussed. So if this patient, you give them R-score and they go into CR, would you still consider transplant because they had the early progression, or you would do alternate and see what happens?
Yeah, that's the part that I don't know the answer. I think, as I said, most of the time, what happens before you start the lenalidomide, you say, okay, we'll get you to remission, we'll do the transplant, but then they get the remission and they like it and they don't want the transplant. Yeah. So I don't think we know the answer. I think it depends on the patient. If somebody is high risk and they have comorbidities and they're doing great on lenalidomide, they have no cytopenias, they have no clots, and they're happy, yeah, I would continue. If not, and if your response is not as perfect and they're young and healthy, I would probably use that opportunity and do the transplant while in their remission. But that's just really, everybody can do it differently, I think. Okay, I am having trouble maximizing my chat box to read these questions, but okay. I think we covered the PET question and then the next question, and okay. There was a question about transformed lymphoma. What to do with patients? Basically, the question is about patients who have transformation to large cell lymphoma after they had treatment for low-grade lymphoma. If I'm reading, I'm sorry, this is really small. I think that's a question. And so what to do with those patients? We have a case report in literature. So let me understand the question, but I don't think, because I don't think that would be a case report. So diffuse large B-cell aggressive lymphoma, such as diffuse large B-cell lymphoma, relapse after treatment. Oh, I think This is a patient that's large, let's say large cell lymphoma, you treat it and they relapse as follicular lymphoma. So probably somebody who had both at the beginning and you biopsy and you see the high grade and treat it and the low grade lymphoma comes back, what to do with that
Yes,
situation?
exactly. Sometimes you would think that the patient already have maybe transformed disease or composite lymphoma and to start with, but if diffuse large B-cell lymphoma went into remission and the follicular lymphoma is just appearing now, I would look at it just as follicular lymphoma, see if they need treatment, if they need indication for treatment or not, and go from there. Obviously, I will do the PET scan and I just do by biopsy and all the investigations as needed, but I will treat it as a follicular lymphoma.
Yeah, I agree. So there's another question about transformed follicular lymphoma to DLBCL. Should these patients undergo an auto transplant after R-CHOP? So let me clarify the question because it's not as simple. So let's think of two cases. Case number one, somebody you diagnose them with follicular and large cell at the same time. So you know they have a de novo transformation and you give them R-CHOP. What do you do next? Or if you have somebody who had follicular lymphoma for 7 years, they had RCVP, and then they had a little bit of, let's say, lenalidomide, and now they're large cell lymphoma, you give them R-CHOP, do you transplant? I think these are two different cases. So basically, transformed lymphoma that's previously untreated, or a transformed lymphoma that's previously treated. Because treatment approach is different for us at least. So I just wanted to clarify the question.
Yes, thank you, Dr. Shadman. And I just want to say that based on what I know, that this answer could be different based on the institutions and experts, and I feel that my answer is going to be a little bit different from Dr. Shadman. But I would treat it as diffuse large B-cell lymphoma, give R-CHOP if we can do R-CHOP, and at that point I would probably not consider transplant right away. But I feel that Dr. Shadman has a different answer about transplant.
No, I think the difference is if somebody's diagnosed with a transformed at the diagnosis, so you do a biopsy, you see a little bit of follicular lymphoma, a little bit of large cell lymphoma, that patient we give R-CHOP and just watch. We don't do a transplant in remission. But if somebody's previously treated for follicular lymphoma and after treatment they develop transformation and you put them in remission with, let's say, R-CHOP, those patients we do tend to send for transplant. So that's the difference. But different styles. The next question, okay, well, I think it's so one of the colleagues has a follow-up comment. I had that kind of a patient previously experienced both low-grade and DLBCL, showed long-term complete remission after treatment for follicular lymphoma. If I understand it right, somebody with large cell lymphoma only got treated for follicular lymphoma. That would be unusual, but maybe I don't understand I don't think if somebody has large cell lymphoma, I would just give him follicular lymphoma type treatment. But that's the comment.
I agree. I would definitely consider anthracycline or like R-CHOP regimen.
Okay, while we're waiting for more questions, and by the way, colleagues can open their microphone and ask questions too. This is a friendly conversation we're having here. Yeah, okay. Oh, what is the role of CAR T therapy? Thanks for that question, because I was gonna ask about it. So what's the role of CAR T therapy in relapsed or refractory follicular lymphoma? And if you can, any of these questions, Dr. Yazdy, if you can't answer because of your limitations, let me know.
Okay, sure. Would you like to go ahead and do the CAR T cell?
Yeah, so right now, let's kind of give a little bit of background. There are 3 CAR T products that are approved for diffuse large B-cell lymphoma. Out of 3, one of them is also approved for follicular lymphoma. in the relapse setting. And I think it's after 2 lines of therapy. So it's a CAR T called axicabtagene ciloleucel or Yescarta or Axicel. So yes, it's an approved treatment for follicular lymphoma with a very high complete remission rate. The toxicity for this specific CAR is a little bit still high. I think you have this cytokine release syndrome that could be severe in I think 9% of patients, and then you have neurological toxicities that are high grade in 15%. So for low grade lymphomas, these are a little bit high in my opinion. And other CAR Ts that are approved for large cell lymphoma and not yet for follicular lymphoma are coming. So the 2 other CAR Ts are a little bit better tolerated. So hopefully in the near future, we'll have those options. But yes, so actually a lot of these high risk patients that we were talking about today, these days are considered for CAR T versus transplant. So we have those discussions very actively. Good question. Another question. Any indication for allogeneic transplant in relapsed refractory follicular lymphoma, or do you prefer CAR T instead? That's another good question.
Yeah, that's a great question. In my opinion, I would definitely consider and discuss CAR T first before allogeneic because of the toxicity profile and the risk and everything and other issues.
Okay, so that's that. Again, as we are waiting for, so one quick thing I wanted to cover, I wanted to talk about CAR T, but thanks to the question, we already talked about it. Oh, I think there was a clarification on the point that patient received treatment for large cell lymphoma and then relapsed with follicular lymphoma. Okay, yeah, thanks for the clarification. Yeah, that absolutely makes sense. So you treat the large cell lymphoma, follicular comes back, you just treat it as a low-grade lymphoma, and that's exactly what we mentioned. So thank you. So that there's a new class of drugs that are not approved for anything at this point, and that's why Dr. Yazdy is not talking about them. But we are very excited, especially for follicular lymphoma. I think there will be game changers in relapsed follicular lymphoma. A lot of people even believe that they may even be better than CAR T therapy or really compete with CAR T therapy. And these are bispecific antibodies. So these are antibodies that target 2 antigens, and specifically they target CD20 on the lymphoma cells and CD3 on T cells, and basically they engage T cells with the cancer cells, very similar to blinatumomab, which is approved for ALL, and I know that it's used in Iran very frequently. The difference is that these bispecific antibodies that are CD20 and CD3 specific, these are full-length antibodies, and unlike blinatumomab, which is a fragmented, it's much smaller molecule, and because of the smaller size, has a short half-life and has to be given continuously an IV and sometimes inpatient. Sometimes these CD20, CD3s are large molecules and they're given outpatient, and most of these are completely outpatient treatments. There are 4 or 5 in development, so I'm not going to talk about any specific bispecific antibody, but just know that they're coming, and you're looking at treatments every 3 weeks or every 4 weeks, or some of them every week. Some of them are IV, some of them are even subcutaneous, and some of them you can stop after 8 cycles of treatment. So I think, and I hope that at some point when these drugs are available, they're definitely much easier to use than CAR T therapy, for example, in Iran. I mean, Blino is already being used in Iran very commonly, so I'm sure that these drugs will get to Iran. And again, there are many of them. There is mosunetuzumab, there is glofitamab, there is epcoritamab, there are many names, and some of them are published now. So there was a recent JCO paper for there was a recent Lancet paper for epcoritamab. There was a JCO paper for Glofi, and there will be soon a paper coming out from JCO for mosunetuzumab. So these are very important drugs for all colleagues who work on lymphomas. These will be the future. So for follicular lymphoma, maybe even as monotherapy. So you just use one of these drugs for a few cycles, I hope, and then stop. And I have many patients who very high-risk patients who failed all kinds of chemotherapy and novel agents, and 3 or 4 cycles into treatment with bispecific antibodies, they have a complete remission, and they're in remission now for more than 2 years. So, they're going to come also for other lymphomas in combination, probably with chemotherapy or other novel agents. So just be familiar and be ready for bispecifics to be available, hopefully in the next, I don't know when, in the next months or years. And I think they will be very important for lymphoma patients. In the meantime, we got another question. M7 FLIPI score, does it change the plan for treatment?
Well, at this time, based on what we don't know, it kind of gives us a picture of the risk profile of the patient and their general long-term picture, probably compared to other patients. But I look at the grade and stage and symptoms and all those criteria for selecting treatment or deciding about treatment.
Okay, any other questions? I think I wanted to, Dr. Yazdy, if you don't mind, some of the very common questions that I always get asked, and I'm sure you do too. So you kind of covered the first line treatment, whether or not using maintenance therapy after initial induction. So that's a conversation we have with I just don't know if one of our colleagues maybe from Iran could comment, or maybe in the chat. Is the current practice to give maintenance? I mean, do you use rituximab or MabThera in somebody who finished the initial 6 cycles of chemotherapy? I wonder how common is maintenance therapy, because these are expensive drugs, and I can tell you we don't use it. So we don't use maintenance therapy upfront because there's no overall survival benefit. There's toxicity, and especially with the COVID-19 situation, we try to avoid antibodies if possible. So, and even before COVID, we would just give 6 cycles of bendamustine and rituximab, and we would just stop, and not even obinutuzumab, because the benefit of obinutuzumab, as Dr. Yazdy showed in the gallium study, was only shown in a study that included maintenance in it. So if you for a treatment that includes induction and maintenance, yes, obinutuzumab is superior from the PFS standpoint, but not when you don't use maintenance, and we don't use maintenance. So I got an answer from, so no, okay. So maintenance is not commonly done even before COVID. And thank you for that answer. Okay. So we talked about the transplant, the allogeneic transplant. CAR T is not available in Iran, so, and I don't know how soon we will have it. So I think allogeneic remains an option for patients still, especially those after auto transplant and relapse. I don't even think the PI3 kinase inhibitors are available. And again, if you let me know, either is any of the 4 drugs that Dr. Yazdy mentioned, umbralisib, idelalisib, duvelisib, or copanlisib, are any of those drugs available? Not that those are the best drugs to use anyways. I can tell you they're there and we use them when we have to, but the side effects are not necessarily easy to manage if you use them for a long time. But I just didn't know if they're, because ibrutinib and BTK inhibitors are available. I don't know about the PI3 kinase inhibitors, but anyways, while they answer, any other points? We're almost at time, so I want to make sure if there are any questions from the audience, or if there's anything Dr. Yazdy wanted to add. Okay, so it sounds like the PI. I'm not surprised, but if I'm hoping that with the novel agents, and I know that lenalidomide is of course available in Iran and it's used, so I think that's probably even a better drug for follicular lymphoma than PI3 kinase inhibitors, but that's my opinion. So let's see, sounds like there's no more questions. Any closing remarks, Dr. Yazdy? Anything you wanted to say before we end this session?
No, I just wanted to say it was really a great pleasure to be here, and it's just been after all of these years after graduation, and It was, thank you for giving me this opportunity. I'm going to also put my personal email in the chat box if anyone has any question or if, any help I can do or anything, please feel free to send me an email and yeah, don't be shy.
Okay, thank you very much again for your time and for all the paperwork, both you and Dr. Yaghmani and her team. I know it was a lot of work. I was just watching. And thanks everybody for joining, and see you I don't know when, but soon for our next session. Have a good day.
Just have a great evening. Bye.